Hello and welcome to the fourth conversation in our Let's Talk Public Health series. There is a silent and growing crisis that is brewing in workers' health in India today. That is why we have this very contemporary topic. After our earlier conversations on primary health care, affordable drugs and medicines, women's health in communities, today, therefore, we are discussing a very contemporary and much less talked about issue of silicosis. About 50 million workers are said to be involved in occupations with exposure to silica dust, leading to several comorbidities that can be fatal to individuals. Silicosis, a condition where inhaling of silica results in almost a fatal lung disease, has been recognized as an irreversible and fatal occupational health disease. The prevalence of silicosis in workers in India is varied, from about 9% of all workers in some states such as Haryana to about 79% in some other states such as Rajasthan. As we dabble with this topic, several questions, hard questions come before us. Is silica really the problem? Or how and in what conditions it affects workers' health is the real problem? The former continues to be the subject of medical texts, whereas the public health dabbles with the latter. Even medical texts tell us that silicosis is completely preventable. However, the prevalence surge in the silicotuberculosis cases and the stories of deaths and impoverishment in the communities say something otherwise. That brings us to today's topic: silicosis and the occupational health perplexities of workers, from medical pathology to public health diagnosis. Certain hard questions are before us as we begin. What preventive measures are in place? Who are the affected workers? How can the living and working conditions of informal workers be improved? Why this disease is not diagnosed and treated on time? How can the health of the workers working in these industries be protected? Why are the safety of the workers at place not enforced, and who is accountable for this? Several public health practitioners have been trying hard for several years to bring this issue to public consciousness. They have advocated strongly for several strategies at the community, systems, and policy levels to address this as a serious public health concern. We are very happy to have Dr. Prakash Tyagi with us today. He is the Executive Director of Gramin Vigyan Samiti, GRAVIS, a non-profit organization based in Jodhpur, Rajasthan in India. GRAVIS has been working in the spheres of health, water security, agriculture, and education nearly for 4 decades. They cover a population of about 2.5 million, living in over 2,000 villages. They have also facilitated the formation and strengthening of 4,000 community-based organizations. Dr. Tyagi himself has both medical as well as public health qualifications and expertise. Under his leadership, occupational health has been a key priority for GRAVIS. Since the 1990s, GRAVIS has done pioneering work on silicosis prevention and control in stone mines that affect the lives of over 300,000 mine workers. Led by Dr. Tyagi, GRAVIS's silicosis program has a very holistic approach comprising training and education, medical support, socio-economic empowerment, and policy advocacy. The organization has also extensively documented various aspects of silicosis to raise awareness and also for advocacy. Through this, GRAVIS has significantly contributed in highlighting the unattended complexities related to silicosis within public health discourses. The Let's Talk Public Health conversation will draw from 4 decades-long work and experiences of GRAVIS. This conversation will focus on the public health diagnosis of the issue and measures that can protect and prevent the health of quarry and mine workers and local communities. Once the presentation is completed, Dr. Aditya, faculty in the Azim Premji University, will hold a focused conversation with Dr. Tyagi on several issues surrounding this silicosis. Dr. Aditya has a background in medicine and in public health. He has been working as a faculty at Azim Premji University since 5 years. His teaching and research are focused on environmental health and food systems. Meanwhile, as the talk progresses and to the conversation, you may please send your questions in the chat box. The team members will be compiling them. We will discuss them with Dr. Prakash Tyagi at the end. Dr. Prakash Tyagi, thank you for making time to talk to us today in this Let's Talk Public Health series. And over to you to present your work and to explain and to help us understand the complexities of workers affected by the issue of silicosis.
Thanks, Edward, for a very kind greetings to all the listeners in the audience. Let me just pull my slides. Okay, so at the outset, I would like to thank Azim Premji University for inviting me to this wonderful series of conversations on public health. I think it's a wonderful initiative. Let me also compliment the university for putting so much of emphasis on public health training and education. I strongly believe that a more capable, more skilled, robust public health workforce will be critical as we move forward in dealing with the healthcare situation that we have in our country. The more capable the public health workforce will be, the lesser will be the burden on the clinical side of the care scenario. So therefore, I think it's a wonderful addition to public health education facilities in the country. And I very warmly congratulate the university for this, for taking this up. The topic of today's discussion is silicosis. Silicosis is a forgotten priority. It is neglected, it is overlooked, it is not given the kind of attention that it deserves. So therefore, I also congratulate the team which is behind this series of discussions to make silicosis today's priority, to make silicosis today's discussion topic, which is important, because by having such discussions, we are going to able to generate more awareness, more understanding about this disease, which has become a big public health burden in the certain communities of India, as well as in different parts of the world. As introduced by Edward, I come from an organization called GRAVIS. GRAVIS is a non-governmental organization, an NGO, which is primarily working in the Thar Desert region of India in the state of Rajasthan. And the desert communities have its own challenges in terms of the temperatures, in terms of the availability of food and water resources, all of which is coupled by occupational health issues like silicosis. I will discuss all of that a bit later. But we have been working on silicosis control for a fairly long time. And so today I'm going to share with you how did we start, what interventions have we been into, what has been our learning, and where have we come. So, silicosis, of course, is a disease of sandstone mines primarily. Of course, it can be found in other types of mines also, but the prevalence rate is highest in the sandstone mines, which are very, very common in the Thar Desert region, as well as in other industries like construction. But mostly we are talking about sandstone mining, which is, again, the state of Rajasthan and a few other states in the country. I think this audience should be very knowledgeable about the mining sector in the country, but I thought that it will be important to set the tone by having some background information on mining in India as well as in the state of Rajasthan, where we work. So India, of course, geographically is a large country, and therefore it has a diversity of landscapes and diversity of mineral wealth across the country. Mining is an important factor in India's economy. It contributes very, very significantly to our overall GDP. It's an important trade. It's an important employment provider, an important mean of livelihoods in different parts of the country. And then different parts of the country have different types of mines. Most of the mines are concentrated in the eastern part of the country, the states like Odisha, Bengal, Bihar, and Jharkhand, where there are a lot of uranium, copper, zinc, those kinds of mines, as well as coal mines. And then in the southern part of the country, Karnataka and Telangana are the states where there is a high concentration of mines. In the western uh, part of the country, the states of Rajasthan, Gujarat, and Maharashtra also have a lot of mines. But generally and by and large, mines are very poorly regulated, with unsafe working conditions, with occupational health risks, and with inadequate facilities for mine workers across the country. Although there has been a Mines Act of 1952, which many of you must have heard about, is in place for a long time. Its recommendations are still not fully fulfilled, and which puts mine workers under great risks and under a lot of challenges. Rajasthan is an important state for the mining sector. It's the second largest state in terms of number of mines, in terms of leases that are given to mine owners in a year. Rajasthan also geographically is the largest state of the country, and it's also geographically very, very diverse in different parts. So there are different types of mines which are found in the state. The southern part of Rajasthan is more known for zinc and copper and bauxite and asbestos. The western part, which is the Thar Desert region, where GRAVIS works and where the silicosis problem is the highest, is more common for stone mining and basically for sandstone, which is used for local purposes, local construction, as well as nationally, as well as is exported to many parts of the world. Also marble, which is the white stone, which is used for flooring. So both these stones are mined in the state of Rajasthan in the Thar Desert region. So primarily sandstone is mined in the Thar region. Thar, of course, is one of the most challenging deserts of the world. And here, mining is coupled with droughts, with lack of food and water supplies. So the overall health conditions of the mine workers who choose to work in these mines are very, very weak anyway, and then they meet occupational health risks. So the situation of mining community in the Thar Desert. Firstly, the number of mine workers in the state of Rajasthan is about 3 million people working in different types of mines across the state. Out of that 3 million or 30 lakh, about 2.5 lakh people work in mines in the region that we are going to discuss further, the Thar Desert region. And most of these mines are sandstone mines, which are the districts of Jodhpur, Jaisalmer, Barmer, Bikaner, all on the western side of the states, all where the Thar Desert is based. The state, the region is drought prone. The droughts are very, very frequent, very, very common. There are very frequent rain failures. The crop productivity is very, very low, very, very unpredictable. Despite of all these challenges, agriculture as well as animal husbandry remain to be the main income generating options for the rural communities. It's basically farming community. Despite of droughts, despite of rain failures, they have to depend on farming because there is no other employment avenue available in the area other than stone mining. So stone mining therefore becomes a major source of employment for rural farmers, for the rural communities. The agricultural season is monsoon based, which is 2 to 3 months in a year. So in average years, in normal years when the rainfall is not deficient, even then the work is available for the farming communities only for 2 to 3 months in a full year. And then of course there are drought years which are completely blank in terms of agriculture, when there is no rain, when there is no crop productivity, then the whole year is blank and there is no income for the rural communities. So in both types of years, either drought years or normal years, these rural farming communities have to find mines nearby, which are scattered all over the place, all over the area, to make money, to make incomes, to run their families. Not surprisingly, these mine workers, these farmers who come to mines, come from impoverished backgrounds, from lower socio-economic backgrounds, from poorer caste groups, tribal populations, and therefore They are extremely poor, and not surprisingly, their literacy rates are very, very low. The literacy of occupational health risks, the literacy of silicosis is minimal, but then the formal literacy levels are also very, very low. They are either illiterate or have very basic schooling. So the educational standards are very, very poor. The overall health conditions of these mine workers are poor. They would meet occupational health risks when they will start working in the mines, but when they come and join, they come with weaker immunities, they come with malnourished health status. They are prone to communicable diseases like TB, for example, which is an important factor in the overall context, and also a number of non-communicable diseases, as well as health risks such as alcohol and tobacco consumption. So their overall health status is very, very poor. Silicosis, of course, is a disease which causes premature mortality. Due to silicosis, which is a main reason for premature mortality, as well as because of other health conditions, the overall life expectancy of these mine workers is much lower. It is not surprising to see a lot of mine workers dying in their 40s, in their mid 40s, because of silicosis or because of the comorbidities that they carry. The working conditions are even poorer in stone mines because they are much smaller, small scale units. They are much more organized, and the compliance, the maintenance of the norms and the rules is even more violated. Uh, Air pollution is a big issue. Silica dust, which is the cause of silicosis, about which I will be discussing a bit later in the presentation, is highly present in the stone mines, in stone quarries, which is inhaled by mine workers. High intensity noise, which is another occupational health risk. But apart from that, extreme temperatures, because it's a drought prone area, arid zone, the temperatures in the summer months would go across the 50 degrees Celsius marks, which means that the breathing will be faster, there will be more inhalation, there will be more possibilities for people to inhale the dust that is going to be of harm. No or limited safety equipment, either in the forms of respiratory masks or in the forms of bed drilling machines or other purifiers that would maintain the air quality. So that kind of safety arrangements are almost unavailable in most of the mines. Economic condition is something that I discussed earlier as well, but after joining the mines as well, most of these mine workers are given very poor wages. About 70% of them are dependent on daily wages, which is very, very low. About 30% of them are considered to be skilled or semi-skilled laborers who are given the wages based on the piecework basis, the amount of extraction of rocks or the amount of shaping and reshaping of rocks that they have done in a day. So they are slightly better paid off, but still very, very low amounts. So in all of this, occupational lung health is an important aspect. First of all, occupational health risks could be seen in multiple ways, affecting different systems, different parts of the body, the nervous system, skin, sensory organs, and then also lungs and respiratory system, which is at risk in the mines where there is more air quality issues like sandstone mines. And that's where mine workers are constantly exposed to air pollution at work site. What complicates the overall situation is the general health in which mine workers are working, their immunity, their other coexisting diseases, their malnourished status of body, and all of that, and also the lack of literacy, which is the lack of understanding and lack of awareness of the health risks that they are facing. So that all of that leads to greater vulnerability of mine workers towards diseases like silicosis, and lung health in all of this is particularly at risk. Pneumoconiosis is a group of lung diseases which is occupational in nature as a result of inhalation of different types of airborne dust particles. So that's what pneumoconiosis is called in medical definition context. And pneumoconiosis could be found in different forms. The most common forms are silicosis, asbestosis, and coal mine worker lungs. Asbestosis and coal mine worker lungs are found in asbestos and coal mines, respectively, in different parts of India. And silicosis is found in different mines, different industries, but the most common prevalence is in sandstone mines. And that's what we are going to discuss. That's what we advocate for. The other important factor which is not to be missed is the double burden of disease. The double burden of disease refers to presence and coexistence of at least one communicable disease and at least one non-communicable disease, and even more maybe in cases. And the double burden of disease is relevant in this case when people have both silicosis and tuberculosis in their lungs, and that's very, very common in mine workers. Silicosis, which is a non-communicable disease, tuberculosis, which is a communicable disease, both affecting lungs, and they can be very, very similar, very, very identical in terms of clinical manifestation. So it becomes very, very difficult to diagnose, and oftentimes they are misdiagnosed, which complicates the prognosis of both diseases and the treatment plans. So the double burden of disease is extremely important consideration. So I'll quickly outline what silicosis is before I go to the next part of my presentation, which is what GRAVIS is doing. So as I said, silicosis is a dust-borne lung disease, which is a result of mostly long-time inhalation of silica dust particles, also known as crystalline silica, which comes out from sandstone rocks or sandstone pieces. When the drilling takes place or when the rocks, big stone pieces are broken into smaller pieces, that's where the cloud of silica comes out, as you can see in the picture, and it's inhaled by mine workers who are in that area or in the vicinity. This long-term inhalation of silica dust causes a irreversible process in lungs called fibrosis, which is the permanent damage of lung tissue, not to be recovered. And the disease, the pathological process, very significantly impact lungs and general health status of the mine workers. As a result of this, the premature mortality of mine workers is very, very common. Silicosis is incurable. It's a very progressive disease. It progresses even more rapidly if the palliative support, if the delay of the disease, so to speak, is not provided. And a lot of mine workers die at the age of 40, at the age of 45, so young age, and they leave behind their families, their wives in the form of widows, their children in the form of orphans, and that creates a huge and vicious socio-economic cycle of poverty, because a lot of these mine workers die under a lot of debt that they may have taken for their families, their treatment, for their care, which remains unpaid when they die, and then the family has to repay the debt to mine owners in most of the cases. That impacts children's education, that impacts children's livelihood opportunities. A lot of young children, as a result of this, have to start working in mines at very young ages, leaving their educational prospects behind. So it's public health consequences, but also a lot of socio-economic consequences of this disease, which are seen in the communities. I spoke about silicotuberculosis, but that's a very significant challenge. Most of the mine workers are prone to both silicosis and tuberculosis, both diseases in terms of their origin, in terms of their development, are quite distinct from each other, but yet they have very similar clinical appearance, and it's very, very difficult to diagnose if it's silicosis or if it's tuberculosis. Tuberculosis, as you know, is curable in most of the cases, where silicosis is almost always incurable and fatal. Unless knowing about the occupational history of the patient and particular chest imaging findings which are very, very characteristic for silicosis, and also the treatment that the patients are taking, it becomes very, very difficult for a practitioner to distinguish between silicosis and tuberculosis. Most of the times, the cases are misdiagnosed as TB, or as silicotuberculosis cases are diagnosed as only TB, and that leads the treatment plan towards the direction of having anti-TB treatment, and which takes care of TB if the TB part is there, but doesn't help the overall progress of the patients. And that's a big challenge in terms of compensations, in terms of prevention, in terms of the management in the communities. Silicosis, depending on how it develops, can be divided into 3 or 4 different types of forms. One of them is chronic form, which is the most common form of silicosis development, which takes at least 10 to 15 years. 10 years is the minimum of exposure to airborne silica of a mine worker. So it's a process of slow development, 10 to 15 years. Sometimes it could be 20 years. But am I still audible? I think so. But there are accelerated forms of silicosis which are less common, and those are the forms which develop after an exposure of between 5 to 10 years of time. That's slower, but a little less common. And the one which is least common, one which is rare, is acute silicosis, which can be developed after a few weeks of exposure up to a few years. So that's very, very rapid, very, very fast kind of development. The exact reasons that why silicosis can develop in some cases so rapidly are still not known. There are some hidden factors behind that. But most of the times, silicosis is chronic. It's a slowly developing disease, and it's a preventable disease. Silicosis continues to be incurable, but again preventable, which makes it an important public health concern. It's a man-made disease. It's an occupational disease. It has been prevented. It has been eliminated in many parts of the world, but it continues to be a public health challenge in some parts of the world, such as our country. The mining sector, of course, lacks healthcare support, diagnostic facilities. The mining communities in Rajasthan or in other states where stone mining is prevalent, because healthcare support and diagnosis are important elements of patients' care. Despite being incurable, silicosis patients can be provided relief, can be provided comfort, can be provided rehabilitation. And diagnosis is important not only for relief and rehabilitation, but also for compensations, either in the case of a living silicosis patient called rehabilitation support, or in the cases of people who have died with silicosis to provide relief to their families. One of the problems about silicosis is that it is considered to be a problem of the past, because it has been almost completely addressed in many parts of the world. For example, in North American countries, in most parts of the Europe, in many Eastern Asian countries, which are the high-income parts of the world, silicosis used to be a significant industrial, occupational health problem in the earlier part of the 20th century, even till the middle of the 20th century. But as a result of constant training and education efforts, and also because of health safety arrangements which maintain desirable air quality standard, a lot of improvement has been seen, and silicosis cases have been reduced dramatically, and new cases are almost not found. And therefore, it is considered that silicosis has been addressed, and silicosis has been completely taken out of public health concerns. But that's not the case in many other parts of the world, which are lower and middle income countries or middle income countries, including India, but also countries like Brazil, China, South Africa, where silicosis still is a big problem. And all of this leads to an understanding that silicosis doesn't need attention, it doesn't need the kind of resources and the kind of efforts that are required for other public health problems, and therefore it has become a forgotten kind of priority. Uh, an example would be that the global silicosis control programs, the one which is led by ILO and WHO, also known as GPES or Global Program for the Elimination of Silicosis, is a good program with a good concept, but with very limited resources and expertise. Uh, uh, that goes to show how much attention is silicosis getting out of public health planning and resource allocation processes. One good thing about GPES is that it has led to formation of national programs for elimination of silicosis in many countries, and India is also one of those countries where national program is there. I'll come to the second part of my presentation, which is what GRAVIS is, the organization that I represent, and the kind of work that we are doing. So GRAVIS, as I said in the beginning, and as was introduced by Edward at the top of the session, is a non-governmental organization which is primarily working in the Thar Desert region of India, which is a drought-prone region. We have smaller interventions, smaller programs in a couple of other states of UP and Uttarakhand. We also reach out to communities nationally when we respond to natural disasters in humanitarian context. We are able to reach out to people affected by different disasters with medical support, food supplies, relief supplies. So in that way, we reach to many states of the country. But apart from that, our work is confined to those three states, and most of it is in the state of Rajasthan. Because we understand that over the last 40 plus years, the one area which we have understood the most is how to work with desert communities, how to provide drought mitigation support, how do we deal with climate change adaptation in the context of droughts. That's where we work, and there are multiple programmatic domains in which we work. There are four key areas of our work, which are water security, agriculture and animal husbandry, very understandably for a desert climate, and also healthcare and education are the two other main programmatic areas. And then we have two cross-cutting, overarching domains of our work that support everything that we do. The first one is about research and advocacy, which allows us to document and compile our learning, our processes, our failures, our way forward. We very strongly believe in compiling our knowledge so that we are better prepared for future programs, as well as are able to share our knowledge pieces with other stakeholders, other organizations working in the same areas and same themes. And community mobilization, because we strongly believe in local ownership and sustainability of programs. Healthcare is the one which is relevant to today's discussions because occupational health falls within that category. And we have been very actively working on silicosis control for a fairly long time. So then what is our work on silicosis prevention and control? Uh, I'll take you back to the point when we started our work on silicosis. In late 1980s or early 1990s or so, when GRAVIS was working on drought mitigation programs in different pockets of the region, it still was a very young organization. It still was a very learning and evolving kind of an organization. Its field workers noticed that there is a lot of TB in the communities, and a lot of people were very, very sick, very, very ill, very weak, very malnourished. And we started partnering with the local TB control agencies run by the government in terms of ensuring that the people who may have TB are screened, are provided the treatment, because TB, of course, is a big problem, but it's a curable problem. But then we started noticing that the TB treatment is not helping a lot of people who look like TB patients. Our team also started noticing that a lot of widows are there in the mining community, young widows, which means their young husbands have died. unusually high number of widows, unusually high numbers of orphans in the communities. And that led us to think that there is something else. There is another public health issue. There is another lung health issue, which is causing the problem. And that led us to more exploration, more surveys, more interviews, and more research to find out what is the issue behind all of this. And then after some time, we came to know that there are occupational health challenges because of the air quality, because of sandstone mining, because of the respirable silica dust which is there in the air. And GRAVIS, in a way, pioneered silicosis control in the state of Rajasthan in early 1990s or so. As a result of all of these initial interventions, many initiatives. There was a Jodhpur declaration which was signed in 1992 or 1993, which brought a lot of civil society organizations. GRAVIS was the convener together, and they agreed that silicosis is a public health challenge that needs immediate attention, that needs extraordinary efforts to be organized, to raise voice, to have attention given to mines and mine workers. At that time, the number of silicosis patients was quite high, and a lot of mine workers were having risk of developing silicosis. So after that, a lot of organizations came together, again in the leadership of GRAVIS, and a campaign was formed in 1993, known as Mine Labor Protection Campaign, or MLPC. The idea behind this campaign was that this campaign would remain a pure campaign. It would never be registered as a formal organization like an NGO, so that it is free, it is independent, it is about raising the voices, it is about advocacy, it is directly connected with the people, and it is run by many, many different organizations. So that was the initial work that was done in the decade of 1990s. Moving forward, GRAVIS had thought that we will need more concrete data and evidences to move forward, to get more support, to make sure that the voices that we have are heard. Keeping that in view, the first ever profile report of mine workers was brought in. In the year 1994, we surveyed mining communities in Western Rajasthan districts, mainly in Jodhpur district, but also in distant locations where the sandstone mines are there and mining communities live in large numbers. Data around their socio-economic backgrounds, their health risks, their mortality patterns, presence of other diseases, the kind of environment in which they work. A very, very comprehensive profile report was developed and published. And following that, in the year 1995, GRAVIS took the lead of organizing the first ever state-level roundtable conference on mining issues. It was called Mines, Mine Workers' Problems and Their Remedies. Justice Krishna Iyer, who used to be a very prominent judiciary figure at that time, was the patron of MLPC and also chaired the first roundtable conference, which was a historical moment in the history of silicosis control journey in Rajasthan. This conference brought more than 100 people from different sectors of society, including CSOs, a lot of government functionaries, a lot of academic people, mine workers, mine owners. Everyone came together, and it was a 2 day event, which led to a lot of important decisions, which proved to be very, very important moving forward. So then, after the first roundtable conference in 1995, GRAVIS started active engagement with human rights commissions, both at the state level as well as at the national level. The National Human Rights Commission, to advocate for silicosis, to advocate for a more functional pneumoconiosis control board. The first pneumoconiosis control board that the state of Rajasthan has was founded in 1965 in one of the medical colleges in the state capital, but it remained rather inactive for a very long time until the advocacy for its more active role started by GRAVIS and by other organizations. At the same time, GRAVIS also believed that the ground level work is important, advocacy and research are all great, but the communities which are suffering, which are facing the health hazards on a daily basis, they also need to be covered, they also need to be benefited. So we started planning implementable projects. We started in a slow way, depending on the resources, but gradually our programmatic coverage of projects expanded both geographically and programmatically. So there are a number of things that we do in our holistic approach of silicosis prevention and control. We try to address different types of problems. We try to look at the medical side of it as well as at the non-medical side of it. We try to make sure that all the stakeholders are a part of the process, and therefore our interventions are divided in 4 or 5 major categories. I will briefly explain all of these to you. The first one is around community mobilization. From the very beginning, we had understood that it's important to make sure that the communities are mobilized, the awareness levels are generated. Once again, in the late 80s or early 90s, silicosis was an alien word. No one knew about silicosis. In mine workers community, in mine owners community, also in the healthcare sector, it was a very less known kind of a term. A lot of people found it very, very new to them. And today the awareness levels are very, very high because a lot of awareness generation has taken place. We also believe and believed in the beginning that the assessment of the situation is important. We have to be solid in terms of what we know. Data needs to be collected. Only then the resources will become a possibility. Only then the future research will be possible. So in the beginning, we did the profile report that I talked about in the last slide. But moving forward, we have been constantly doing more assessments, more data collection exercises, more baseline surveys of new areas where we are starting the new projects. That helps us in comparing the data, that helps us in evaluating the programs that we are taking forward. In ensuring sustainability of programs, the formation of community groups is important. And while the population is very, very scattered in the Thar Desert, it's not very highly concentrated in one particular location. The distances are always a big issue. And also the sandstone mining industry is a small scale industry, which means not a large number of people are working in the same quarry or in the same mine. Yet it was important to form the groups of community. We have been working on forming interest groups of mine workers, as well as self-help groups of women in the community who would be trained, who would be provided knowledge support, training and capacity building skills, their understanding of silicosis and how they can participate more actively in the program. The formation of interest groups later on led to forming of smaller mine workers unions in certain pockets. But the initial step was to form smaller groups and their training and capacity building. I have already talked about Mine Labor Protection Campaign, which was a crucial initiative in the 1990s that provided space to a lot of organizations. GRAVIS was one important collaborator, but there were many other organizations that played very, very important roles in strengthening of MLPC and in raising the collective voices of mine workers in front of policymakers. Working with mine owners to mitigate a disease like silicosis is important because mine owners are the ones who are going to ensure that there is adequate amount of health safety, there is adequate amount of arrangements in the interest of mine workers' health, which is oftentimes ignored in the interest of profit. And it was initially very, very difficult for us to communicate with mine owners because coming from a CSO background, coming with a objective of benefiting mine workers, we were seen as troublemakers or as enemies. But gradually, with constant efforts, we were able to find voices, and therefore we had been organizing a lot of dialogues, a lot of meetings with mine owners, and gradually we were able to convince quite a few of them. And today, as we move forward, we have a lot of mine owners who support us because they believe that silicosis control is going to be in the interest of their business and in their mine workers workforces as well. Uh, Strengthening local leadership in the communities is important, which we have been doing by training and building these interest groups and self-help groups. Public hearings is an important initiative that we started in the early 1990s. And the idea was to bring different types of stakeholders together, the mine workers, mine owners, healthcare providers, other relevant local authorities, government departments, CSOs, and academic organizations. And the idea was to listen to problems of mine workers, also of mine owners, and to collectively think of remedial measures that would help. So this is something which we started, and that is something which is still continuing in different pockets. And it's a very rewarding kind of an activity. We have also been working closely with the relevant service providers like the health department, the TB control department, nutrition and sanitation services, other departments focused on social issues, education of children, women empowerment, to give a more holistic approach to our overall program. GRAVIS believes that it has played a critical role in local level sensitization of the issue in that point of time, early 1990s. But also we have been able to raise the voice of silicosis affected victims in the country, in different parts of India at the national level. And we have also been able to raise the issue in international forums to attract more interest, to have more resources, more partnerships. And we have also been organizing a lot of dialogues between different types of stakeholders so that there is collective understanding of the solutions that are being undertaken. A second category of our interventions is around training and capacity building. The target groups are multiple. Mine workers obviously are the primary target groups, the victims, the affected community, which need training, education, awareness generation on silicosis, but also mine owners because they complete the picture. Without them, silicosis control is impossible. They will have to play their own roles, and therefore their understanding needs to be enhanced. Health workers are also an important part of the process. They are the ones who are supposed to deliver health care, either the government health workers or informal health workers in the communities. GRAVIS and other CSOs are important players, important stakeholders, and they have been playing critical roles in the highlighting of silicosis as a public health challenge. But then their workers, their staff, their team members also need to be knowledgeable about silicosis and about occupational health risks. And finally, the CBO's representatives, which are self-help groups, interest groups, their understanding of silicosis and of lung health also needs to be enhanced. We organize a wide range of training and capacity building initiatives, training camps, training workshops of shorter duration, of longer duration. Topics that we cover are mainly 4 or 5 types of topics. Occupational health in general, what does it mean? What is silicosis as a disease? And of course, the training contents would vary from depending on the audience. It would be more simpler in the context of mine workers. It would be more advanced in the context of health workers or CSO workers. The first aid trainings in mines are also an important part of our overall approach, which may not be directly linked to silicosis control, but that provides support to mine workers in dealing with injuries and trauma and acute conditions like heat stroke. We have also been organizing a lot of self-care and preventive health behavior trainings because mine working community also need to understand their own system of body, how the organs function, what diseases are there, what health risks they face. and how they can protect themselves from all health risks, including silicosis. And in that context, we have also been doing work on nutrition and hygiene trainings, which are important contributors to mine workers' health. And TB, of course, is significantly important because of its association with silicosis and because of its coexistence with silicosis. So moving forward, the direct health support, which is the third category of our work and very important one, direct health support, which we provide through running a rural hospital, which GRAVIS had established for rural population in general, but also for mine workers to address diseases like silicosis and also TB. We also run satellite clinics in different areas and remote villages, which become accessible for mine workers in different parts of the desert. We have also been reaching out to the communities by outreach medical teams for early detection and care support of silicosis to make sure that we reach the last mile in distant locations of the Thar Desert, including in the areas which are very, very far from urban settings or from nearest hospitals. We have also been coordinating quite effectively with the government provided health services, including Silicosis Medical Mobile Unit, SMMU, which is a new initiative which was taken up last few years ago. And this is a facility which travels across the mining areas, goes to the silicosis patients or affected victims, and provides them the support. GRAVIS, because it has outreach medical teams, is also able to provide palliative support in the community, which is to ensure that the mine workers who are already affected by silicosis, while they will not be cured, they can be given some relief, they can be given some comfort, and the longevity of their life can be increased by that palliative support. Other forms of direct health support interventions include diagnostic support, which is crucial for the compensation part, which is now being provided by the government of Rajasthan as a result of advocacy. TB control is crucial because TB is coexistent with silicosis in many cases and is misdiagnosed and affects the overall prognosis of silicosis as well as of TB itself. Nutritional support, medical nutrition support through supplements, which is provided by our medical teams during the organization of medical camps, but also non-medical nutrition support, which is in the forms of enhancing agriculture and horticulture in the communities by setting up farming units or by setting up horticulture units. I will not go in the details of those activities in the interest of time. And then preventive measures at the work site, which includes use of respiratory masks, locally made respiratory masks, as well as technologies like wet drilling or air purifying technologies. Wet drilling is simple, although availability of water is a big challenge in the desert conditions. But other air purifying technologies are expensive and are still not a possibility in the context that we are talking about. The other category of our interventions is around research and advocacy. We very strongly believe that what we have done on silicosis must be technically understood, must be analyzed with the help of quantitative and qualitative data, with the help of case studies, with the help of lessons to move forward, with the help of recommendations. We have done a large number of research studies which are listed here. Few of them, we have done more than 15, both in English and Hindi. Only the English ones are listed here. The first one was the profile of sandstone mine workers in 1994. And since then, we have moved on while covering silicosis, but also covering different aspects of the disease, like aging with mining, how women miners are affected, what is silicotuberculosis in this context. All these studies have been very helpful for us to move forward in better implementation and monitoring of our programs. And all these studies are available on our website for any of you to use. Advocacy is important with research, and we have been doing a lot of advocacy efforts, reaching out to the Human Rights Commission, reaching out to the local government authorities. The first roundtable conference was in mid-1990s, which you heard about in the beginning. But since then, we have been organizing a lot of state level, in the state of Rajasthan, and national level events. Labor Day is important to highlight silicosis problem. And also we have been making a lot of efforts to reach out to global audiences in events like American Public Health Association's meetings, in International Union Against Lung Diseases conferences, and TV meetings, to make sure that the research community, the donor community, understands the problems of this particular region, this particular public health problem, and comes forward to provide technical and financial support. Lastly, we are very holistic in our approach, and we believe that not only medical or not only public health interventions would support silicosis control. It's a disease which has a socio-economic impact. So therefore, we have also been focusing on school education of mine workers' children in their communities. We have created and set up a number of schools, primary schools, which we run through the resources that we are able to raise. We have been doing a lot of meaningful work which suits the desert conditions on water and food and nutrition security, which would improve the general health status of mine workers. And then there is also a focus on livelihoods and creation of self-help groups, so that there are alternative means for the community to have more incomes, and they are not only dependent on daily wages which come from mining. We have also been quite innovative in our journey so far. We have been bringing in new ideas as a result of consultation with the local communities, as a result of feedbacks from other organizations, the feedbacks from our partners, academic partners and funding partners. We have been experimenting with locally made respiratory masks, made of thin masks, which are manufactured by the self-help groups which are in the communities. So they are very low cost, very simple, very easy to use. Wet drilling is crucial because all the silica which generates in the mining industry is a result of drilling, or is a result of breaking the stone pieces into smaller pieces. And at that time, if there is water on these rocks, then the possibilities of airborne silica will be minimal. The challenge, though, is that it's a drought-prone area and water is extremely limited in terms of quantities. But then there are ways to find rainwater harvesting structures to recycle the same water which is being used, which we are promoting. And if wet drilling takes place, then of course silicosis prevalence goes down quite significantly. We have also been able to develop training courses for different types of audiences, health professionals, health workers, NGO workers on occupational lung health in general, as well as on silicosis. And we have been working very closely with the DOTS program, which is for TB, as you know, because of its close association with silicosis. We had designed a nutrition curriculum for the mining community so that they understand about their nutritional needs, about their diets, and they just become more knowledgeable about the role of nutrition in overall health, in TB, in silicosis. And also arid horticulture units is an experiment that we have been doing in the mining areas, through which we are trying to promote cultivation of fruit and vegetable crops. And the school education, we are trying to make it very creative, beyond curriculum, to make sure that they get a more holistic experience of life. There is a lot of data on the slides. So I will not go through the whole data, but so far we have been able to reach to 2.5 lakh mine workers in the mining communities and their family members with the help of the programs that we have been doing. We have been able to reach thousands of mine workers with lung diseases, with medical help, with diagnostic help. A number of advocacy events, a number of research studies have been conducted, and we have come a long way. So what has been a result of our journey so far? Firstly, as I said earlier as well, the awareness levels are much greater. Silicosis was almost not known. Only TB was known. But as of now, almost every mine workers, almost every health worker understands silicosis well, if not fully, but at least they are aware of the the disease, its genesis, and how it can be prevented. That's a great achievement. There have been effective partnerships in the beginning. Different types of organizations started collaborating, and they are still collaborating in different forms. Uh, Pneumoconiosis Control Board has been reasonably active of late, and it has been partnering with a lot of other organizations. Government is reaching out to CSOs. CSOs have been working with the community groups, and also there has been an important role of the academic and research organizations in the entire effort. I wouldn't say that the entire concern has been resolved, but the health safety arrangements are much more improved. There is greater awareness, there is more visibility of use of bed drilling, use of respiratory masks. It's a slightly changed scenario. A reasonable amount of data and evidence is available because of the efforts of GRAVIS as well as of other CSOs and academic organizations. In the beginning, when we started working, literally no data, no evidence was available, but now there is some data and evidence which is available, of course, which needs to be taken to the next level. And because of holistic interventions, there is socio-economic development of the communities with more children going to schools, more empowerment of women. I will be wrapping up in a couple of minutes so that there is time for discussion. Uh, so what have we learned as a result of our work on silicosis in the last 35 to 40 years? That in the context of the state of Rajasthan, in the context of the Thar Desert, many other states of India where silicosis is still highly prevalent, it's a problem of present. It's not a problem of history. It's something which exists, and it's something which is going to exist for a long time unless important public health interventions are undertaken. Silicosis has health consequences, but it also has far-reaching socio-economic impact, not only on silicosis victims, but their families, their community members, their children, their wives, and those impacts are extremely visible in the communities that we work with. Silicosis, of course, is mainly confined to an extremely vulnerable target group, which is sandstone mine workers. It could also be in some other industries, granite, gold, diamond mining. But majority of cases are from the stone mining, which are a vulnerable target group confined to certain locations of India and other parts of the world. With a holistic approach like the one that we have adopted, the challenge can be mitigated, not quickly, but gradually. But there is possibility of bringing mine workers out of this public health crisis. But in order to do that, a long-term focus and vision is required. What we have been able to do, which is some change, has taken place as a result of more than 3 decades of continuous efforts. Overnight, the change is not going to be possible. Public health approach is critical. A lot of people in this conversation today are public health students and faculty and activists. It's a disease which requires care and diagnostic support, the medical side of it, but it's a disease which requires public health interventions as well, focused on training, education, partnership building, social initiatives. So it's a critical public health problem. As I said, we have some data, some evidences, but more is needed, more data is needed, more research is needed in order to have more programs, in order to have more policies, to have more resources, which is always a problem. And therefore, more advocacy is required to have more resources. More priority needs to be given within the health policies and programs to diseases like silicosis, which are, as I said in the earlier slides, is a forgotten priority and is poorly resourced and is given limited attention in public health policies. We, of course, need more partnerships. CSOs are working in the occupational health sector, but very, very limited numbers of CSOs are working in the health sector. We need more CSOs, we need more community-based organizations, and we need more academic partners, public health schools like Azim Premji University School of Public Health, That will strengthen the workforce, that will strengthen the efforts at the ground level. And if CSOs need to continue, if more CSOs need to be brought into the scene, their capacity building is going to be an important priority moving forward. So I will come to the end of my presentation. In the battle against silicosis, we shall overcome one day, hopefully. Thank you for your attention, and I look forward to having more discussions moving forward.
Thank you very, very much, Dr. Prakash Tyagi. This was a very, very insightful presentation. It has shed light on the grave nature of silicosis as a disease and its multiple social ramifications for millions of people in Rajasthan and in India, elsewhere in India as well. You spoke about the very important work that GRAVIS has been doing over 35-year period. This is really a lot of experience, and you spoke about the multiple different interventions and innovations that have been done. I think there is so much to learn from GRAVIS, and this presentation was a great start for us to even dig deeper to understand more about the work that GRAVIS has been doing. So I'll just take a few minutes to initiate this discussion with you before we go on to the audience questions. Just to understand a little bit more about some of the other actors involved in interventions as part of the problem of silicosis in Rajasthan. So we understand that the Rajasthan government put forth a policy in 2019, the policy on pneumoconiosis, including silicosis, detection, prevention, control, and rehabilitation. So what previous gaps in policy has this policy been able to address with respect to silicosis and benefit the workers in Rajasthan?
Thank you, Dr. Aditya. The first gap the policy is addressing is that there was no policy, and now there is a policy. From a point in time in early 1990s, when there was a gross denial that silicosis exists in high numbers, when we started advocating for more programs and more attention, to come to a point in 2019 when there is actually a policy is a big milestone achieved. And when there will be policy, there will be more programs, there will be more interventions. So at least there is a beginning. And also an indicator that silicosis exists, although silicosis used to exist in much higher numbers in 1990s, but still it exists, and the policy is going to be crucial. As I understand, this is the first ever pneumoconiosis policy in the country, so it's a landmark initiative. It's a bit early to assess its effectiveness because it's been only 5 years, but it has been addressing a lot of gaps that existed earlier. Although everything was there in bits and pieces in scattered forms, but this policy brings different elements together on one piece of paper. It organizes everything. I think one of the most important things that it does is to have a more clear understanding and plan for compensations.
Okay.
Compensations to the silicosis patients who are living with silicosis, as well as to have relief for the families who have lost people with silicosis. That compensation plan is more clearly laid out, and hopefully it will be clearly implemented. And the policy also talks about a very clear financial mechanism to run this particular thing. So that's one important thing. The other thing that this policy does is that it puts adequate amount of focus on prevention of silicosis.
That's
control has been in forefront, and rightly so. The ones who are living with silicosis need to be relieved, need to be given support, need to be compensated. There is absolutely no denial. But prevention is the key, because we don't want more people to be affected by silicosis. So this policy is comprehensive in that context, which was not there earlier so strongly. And then the other thing that I would like to say is that this policy talks about partnerships and also about the civil society organizations, the CSOs, their roles.
That's great.
Which is an important contributor to the future interventions. There are a number of policy gaps that were there, and they have been addressed by this new policy which came out in 2019.
Okay, that's really nice to hear, especially the part of the compensation. We had heard earlier, and I had the nice privilege to visit your organization in 2011 as well. And based on what we have heard from friends in Madhya Pradesh, that even to get compensation is a great hurdle for many households. And so that this policy has addressed that important gap, that's really nice to hear. And you say that prevention again has become an important part of this policy, which clearly as public health people we are primarily concerned with. So that is also very nice to hear that prevention has come in more strongly, and that some of these processes have become more streamlined along with partnerships with civil society. So this is very good to hear. Of course, yeah, you mentioned that it's been only around for 5 years, that it's hard to evaluate what has been the impacts of this policy. But have you seen any progress in terms of what has been articulated here and in terms of what is happening on the ground?
Sorry, I missed the last sentence that you said. Can you say that again?
Sure, sure. So I just said that though it may be hard to evaluate whether this policy has been effective, but do we see any progress in terms of how this has affected implementation and processes on the ground?
I think policies are great if they are fully translated into action. And as you said, it's early days to come to a point where we can evaluate and where we can say it has been effective or not. But in order to be implemented, in order to be acted, the first requirement is that it should be disseminated. And the 2019 pneumoconiosis policy still is not fully disseminated. Rajasthan is a state which is very isolated anyway in terms of the population settlements. A lot of
Right.
CSOs, a lot of community-based groups are not fully aware of what the policy is, what does the policy mean, what components it has, and how it can impact them. So the first step will be to have more widespread dissemination. And the policy document in itself is comprehensive, and therefore it may not be suitable for everyone to read, to understand its contents. Not everyone has that technical understanding and expertise. It needs to
Right.
be translated into something more readable, something more understandable, and then it needs to be disseminated widely and in across the stakeholders, and then only we can think of a better implementation of the policy. I think civil society organizations again are important stakeholder because they are the ones which are connected with the local communities, and the policy talks about their effective roles, but so far we haven't seen the kind of effort that is required for awareness generation through using civil society organizations for dissemination of the policy. The other thing that I would like to highlight is prevention is an important aspect of this particular policy, and I appreciated that in the last response to your question. But then the reality is that wet drilling, which is supposed to be one of the main constituents of this policy, and also a vision of having more advanced technologies, machines and tools and measurement tools, which all sounds great, but it seems to be a priority which will come up in existence after some time because the resources are very limited. The kind of
Okay.
infrastructure that is required, the kind of resources, financial resources that are required, are just not available in this sector in the mining community. And therefore, to think of those possibilities at this moment is going to be difficult. And last but not the least, you did mention about compensations, and I think more compensations are occurring, more compensations are taking place, but still the percentage of the compensations is much more lower than the overall problem. There are issues with registration of patients in the online systems. There are issues with misdiagnosis. There are issues with certification. So there are still some loopholes, and that will only be addressed by having more robust partnerships at the ground level,
Right.
enhanced understanding and knowledge levels of healthcare workers because they are crucial. And if they are not able to understand silicosis fully, then they will not be able to diagnose silicosis. So the compensation front has gotten a bit better, but I think there is a lot of work which still is required in that context.
Okay. So there is still a long way to go, though we have a nice policy right now in Rajasthan. Thank you for that response. Maybe just one more question before we move on to the audience question. And you did mention about the fact that overall silicosis prevalence has come down, which was great to hear from the 1990s comparing to the 1990s. And you also mentioned a little bit about initially the mobilization and the community mobilization as an important part of the work that was done. You mentioned about the mine labor protection campaign and how various activities have taken the communities forward together. Uh, how have the workers directly been part of some of this mobilization, and do they form collectives, and do they see any such collectives as an important as having an important role in improving their working conditions? And is this something that you have observed, and especially in the context of the policy as well? uh, do any collectives or unions of mine workers exist? And keeping in mind that mining is not coming down in Rajasthan, it might be maybe at the same level as before. Uh, how will this become an important part of improving the situation of workers?
The situation in sandstone mining industry, particularly, which is the place where silicosis is highly prevalent, is slightly different because it's a very small scale industry. Average size of workers in a mine would be 20 to 40. Even in the bigger mines, in the bigger stone quarries, the maximum number of mine workers would be 50 to 60. So it's a much smaller kind of units in comparison to other mines where the numbers could be very high. The other
Right.
issue with the desert setting is that the population can be very, very scattered, isolated from each other. People are living at great distances from each other. So therefore, it's slightly more difficult to organize mine workers in big numbers physically in terms of having them together in meetings, in discussions, in advocacy events. Having said that, communities' voices are important. Community mobilization is something that we have been doing quite regularly, even in smaller numbers. And as I said earlier, we have been focusing to form smaller groups like self-help groups or community interest groups, which are still able to brainstorm within their groups possible solutions moving forward. And then as a result of this, some unions have been formed, but those are in the small numbers. But that's the nature of stone mining. It's small scale, more unorganized. But in this process, the communities have played an important role, even if they continue to be in small groups. They have provided important feedback. They have provided important suggestions to improve health safety conditions, and many of them have been taken into account in the pneumoconiosis policy of 2019 that you see. So community mobilization must continue. It's important. It's important to ensure people's participation, even if it's not unionized. It could be in small groups.
Thank you. I have many more questions, but in the interest of listening to the audience questions, I will request my colleague Edward to now join us, and he will take the discussion forward with some of the questions that the audience has posted. Thank you.
Thank you, Dr. Prakash and Aditya. That was kind of a very interesting light on the policy, how it operates, and of course, your fabulous presentation. And thank you for taking us to the world that we do not know about the workers' world and your Thar Desert and what's happening there to the health of the workers. There are a couple of very interesting questions from participants. So, as public health people who are interested in public health, we look at health systems as central to our interventions. So, there is a question around, about how can the health system be more proactive in detecting and having accurate diagnosis and also reporting silicosis on time so that there is no kind of a confusion. So, do you think if a proactive health system can actually do a lot to the health of the workers? What is your kind of experience and opinion? I'm saying view on this.
Absolutely, it's an important question, and it's important that the understanding of silicosis is there in the healthcare sector. People are knowledgeable about it. We have experienced, particularly in the beginning, that the knowledge levels of healthcare workers were very, very limited. And that is because silicosis is not seen in daily life. It is confined to a very small group of people in particular locations, in particular occupation, and in a routine medical practice, so to speak, or in a routine day-to-day healthcare work that the health workers do. Silicosis is not seen, and therefore it becomes very, very academic. It becomes a very, very textbook kind of a word, and people are not familiar with its clinical manifestations, are not used to see it practically. And so, therefore, a lot of efforts need to be made in medical education, in healthcare workers' trainings, so that they understand silicosis. We also must be reminded that our health system is comprised of both government health workers as well as of private health workers. And all the work that we are
Yeah.
doing in terms of raising the understanding, raising the educational levels of the healthcare workers is from the government side, because silicosis is not even a priority for the private medical sector, which is one of the major contributors to our healthcare services in the country. So we need to make it a priority. We need to make it an educational priority in different curriculums, different training programs. A more trained, a more aware health workforce on silicosis will be more effective.
Okay, okay. Thank you for that. I think it's very important to link both medical education as well as health systems. So, linked to that is, other question in a lot of our educational pedagogies, curriculum, we have made tremendous advances. So, as you refer to the medical education, do you think occupational health has got its priority in the medical education curriculum or sensitizing, let's say, medical personnel in their early formative ages? At what level the occupational health is getting its kind of a due space in this, according to you?
It is not getting the due space that it requires to get. Occupational health gets minimal attention because, again, it is not considered to be something that the future health workers or the future medical practitioners or even the public health workforce would be encountering because of its isolation to certain population groups. And even if the academic knowledge is provided, it is not coupled, it is not strengthened with the practical exposure. And unless the practical exposure is provided to trainees, to students, the knowledge is going to disappear very, very soon. So what you study in a health, public health course or in a medical program 10 years ago is hardly remembered unless you are engaging in it on a daily basis. So I think in all types of trainings, even public health courses, practical exposure to occupational health issues need to be given. The learners need to be taken to sites. The learners can be associated with organizations like ours so that they can see the reality firsthand. And only then the education is going to be comprehensive and sustainable.
Yeah, so we also speak about your presentation actually brought out so many other aspects of what is happening to the households and the communities, and the linkages you spoke about the orphans and widows is something that is a telling story about what it's not only what happens to the mine worker, but what happens to the mine worker, how it impacts the community, households, people, and the communities. So, since you have been involved so intensely with the communities, suppose let's say there's a question around the widows who are left behind. What kind of additional burdens, healthcare burdens that are incumbent on them, maybe or physical, mental, whatever other issues. So have you seen any of those, and are there any efforts by the state or others to address the concerns of widows, and especially women who then bear the burden of the households and the economy and raising children, all that, maybe the debt also left behind by the mining worker or the healthcare. So what is the scene around that community of widows or women who are left behind?
Most of the workers of mining community come from very impoverished backgrounds where it is given that women will be illiterate, will be uneducated, will be confined to households with no roles, with no decision making power, with no knowledge. And when suddenly their husbands die, they're left with nothing. They're left with debt on their family, and they have the responsibility of taking care of their children. So there is a kind of a huge amount of struggle that these women have to go through. And most of these women find themselves in working in the same mine where their husbands used to work. They would not do the same work because of physical requirements. They would not be drilling or breaking the stones, but they would be doing smaller physical tasks like cleaning of the site, transportation of the rocks. All of this also puts them in the exposure of silica dust, and sometimes they can also develop occupational health problems, occupational lung health problems. The same is with the children. Children are unable to go to schools in the absence of their fathers, and many of them in their teens, they have to start working in mines to repay the debts or to run the families, and the education or other livelihood opportunities remain not an option. And this is the kind of vicious cycle that they have to go through, women and children. So therefore, it's extremely important to address the issues of women, which we have been doing by training, capacity building, vocational training, so that they can find alternatives in economic activities, in economic empowerment, and children's education, so that children understand that there is a world beyond mining, there is a world which provides more employment avenues. Only by getting them on the right path in the educational way, they will be more open to more options. So the societies definitely are impacted, and the women and children of the deceased mine workers' families are particularly impacted, and we put a very strong focus on having that approach in which mine worker is looked at as a family unit and not alone.
Okay, okay, okay. Yeah, and another question that has come from one participant is, related to of late in the last 10 years, lot of different cards have been flowing into our pockets, Aadhaar card or that card, this card, health card, Ayushman card. So, given this health cards, and health related facilities, they may not be adequate enough to address mine workers issues. Do you think a kind of identity card to the mine workers when they go to a health center, so that they can have a priority in their health treatment and diagnosis, would that be help, or is it already there? What is the situation of how do an hospital identify somebody as a quarry mine worker or a sandstone mine worker? Does he or she get priority there to adequately address the issues?
Two things. One is that these identity cards, like Aadhaar cards or other cards, are required for the registration on online portals to apply for
Okay.
compensation. And even that is very, very difficult for most of the mine workers because the process is so complicated, and they will not be able to do it unless supported by an e-mitra or a CSO worker. So they require help. So that process is a bit challenging, and is resulting into a lot of mine workers are not able to getting registered. But apart from that, the kind of identity card that you are talking about are not there. Is something which should be there, something which is being advocated for. In the past, there were no records at all of how many mine workers are working in the mines, what daily wages they are getting, what are their names, what are their addresses at all. That has been checked a little bit with more organized records, but the identity cards that would provide them the health services is something which is for future and something which is not available right now. And that would definitely make it much more easier for the mine workers to access health facilities. It would be possible only in the cases of government health facilities, but at least there will be a beginning.
Okay, okay. So there is a comment saying that recently Rajasthan government made Aadhaar mandatory for treatment and compensation for silicosis. Do you think it adds to the complication, or it is a method to make healthcare more accessible to mine workers? What is your opinion on this?
It's both. It's a complication because a lot of mine workers may not have Aadhaar cards, or they may find it difficult to, as I said, in the case of registering online, find it difficult to use the technology. So in that way, it's an obstacle. but it's a good thing as well, so that the other populations are not benefiting from the program, because the resources at the end of the day are very, very limited, and even more limited for the mining population. So the idea is that the benefit goes to the real needy groups in the state. So it's a combination of both.
Yeah, there's a related question. Thank you, Dr. Prakash, for that. From colleagues from Rajasthan. If in the medium to long term compensation is cheaper than wet drilling, then do we expect wet drilling to be more utilized? Means even in terms of economic sense of how do you look at it? Do you think that is a kind of a feasible option for government and the miners? I'm saying the mine owners.
I am not an economist, so I don't have an economic answer to this. Maybe it's economically cheaper or not. But then public health is slightly different from economics, and in public health, one has to balance all aspects. Compensations are about people who are suffering with silicosis. Compensations are about people who have lost their family member as a result of silicosis, whereas wet drilling is about preventing future cases of silicosis. Both are equally important, both need attention. The resources, of course, are limited, but that's how the approach needs to be.
Yeah, thank you very much. There are some more questions, but in the interest of time, let me more or less ask this question, which has been running in my mind for some time now. As Gravis, as an organization, a team traversed the 4 decades. I'm sure it has been a very, very, challenging journey as well. We would like to, while you have crossed, the two millenniums, previous and now, and you have seen the changes, the new technologies, but things have not changed. Some things have changed. There are promises, but there are continuing challenges. I would like to hear from you, from as a university, and from from on behalf of my colleagues, what are the challenges that you have faced in this? And this is first question. Second one is, what still keeps you going? What are the hopes and satisfaction that you have that keeps you going on and on? And maybe if you can throw some lights, insider story with some points that you have, that would be great.
Yes, thanks. Challenges have been there. When this whole journey started 35 years ago or so, there was a lot of resistance from a variety of stakeholders. Mine owners community was one who believed that these are people who are here to destroy their businesses, to destroy their profits, and spoil the game for them. It was quite difficult to navigate with that situation, which took us some time, but we were able to come to a point where there is some sort of an understanding. And apart from that, there was a gross denial by a lot of people, including research and academic organizations, that silicosis may be there, but it's not in that large number, which requires that kind of effort, that kind of attention. And that was a big challenge, and we were able to come through that challenge by collecting data, by having surveys with mine workers, by collecting chest images of multiple mine workers. To come with evidence always helps, and we were able to mitigate those challenges. As we moved forward, and as we are moving forward continuously, a big challenge is that the disease doesn't get the kind of funding, the resources which are required to organize interventions in the communities. And it's also not the research focus for academic organizations. So there are very few, very limited partnerships which are there in terms of resources that would allow the programs to function. We have been constantly working on silicosis control for 35 years with the help of projects, but those are very, very small, very, very limited, and very, very unreliable funding sources. So we hope that that challenge is met when there will be more policies, when there will be more research and data. What keeps us going is the result that we have seen so far. It's been a slow process, but for a disease which has been existent for decades and for hundreds of years, we have come so far. We have come so far in a state which is quite underdeveloped, has a lot of other socio-economic challenges, but we have been able to make the progress. We have been able to get the kind of support that we hoped for in the mining community as well as in the mine owners community. And we have also been able to collaborate with a number of civil society organizations. So there have been quite a few positives that keep us going, and we hope that in the next 2 or 3 decades, we will be able to reach a position where the new incidence of silicosis will be minimal, and we truly believe that it is going to be possible. We also believe that universities like Azim Premji University can play a more active role with having more research focus, with having more data by associating with organizations working at the ground level, because university voices, academic voices are heard and are taken more seriously. So I think there is a lot to hope for, and we are hoping for the best.
Okay, thank you for that very hopeful note. I just want to also, education spheres and domains have massively expanded. While we were putting together our own MPH program, we realized there are more than 100 and now 1520 MPH programs in our country. In addition to the medical community medicine, on a hopeful note, there are more youngsters, let's say, are opting for public health. And you yourselves might have been quite young when you began. So if we have to give a takeaway message from you to the youngsters, keeping this issue of the most marginalized, I'm saying caste, class, gender, impoverished communities who are facing, what would be your kind of a one or two messages to the youngsters of today, who are opting for public health?
Public health is a critical component of healthcare systems. Without public health, the efforts of the medical side of care will remain incomplete, unachieved. Public health is one aspect of overall healthcare system which is going to ensure that people live healthy lives, and it's extremely important in terms of the prevention of diseases. So first of all, please understand the importance of public health. It is not a supportive side of healthcare, it's an essential side of healthcare. Public health, however, needs a focus which is broad, which is comprehensive, which is holistic. So have an open mind, have a broad vision, and have sustained efforts in advocacy and research in dealing with public health problems like silicosis. Public health impacts would not be visible in short term, they would be visible in long term. So one has to be more focused and more ongoing with its efforts. And please do not undervalue your importance in the healthcare system, in healthcare scenario.
Thank you. I think that is very very inspiring and kind of a call to the young generation to opt for public health with right perspectives. And thank you, Dr. Prakash. It has been a very very inspiring talk. We have heard about Gravis's work, but it was nothing. It is like a small capsule that you have presented to us. Your 3 4 year decades of journey in a short time, with so many kind of anecdotes, stories, your interventions at the systems level, communities level, civil society, your partnerships, a multi-pronged approach that you have presented, which requires from all of us to mitigate the suffering of workers affected by silicosis, to do much more for early detection, early prevention, and to save these lives. As we know, mitigation of suffering is the great value in both in medicine and public health. And I hope your message stays with us, goes across to various people. And thank you for your time, and thank you for presenting this so beautifully. So we have overshot with some a few minutes, but doesn't matter. We have stayed on with you, and it was a great pleasure listening to you. And thanks again for this wonderful talk, conversation, and answering our questions and throwing light on this issue. Thank you so much.
I again thank Azim Premji University for inviting me for this talk, which I think is a very important topic. I also thank all the listeners, all the public health fraternity for being a part of today's discussion. And I hope the discussions around silicosis continue. Thank you very much.